Hello guys, welcome to our channel. Today we are going to discuss about the pharmacology part 3. In this part 3, I am going to focus on the general pharmacology, antimicrobials and the miscellaneous topics. So before you watch, please, I will recommend you to watch the part 2 and part 1, which is very important. Almost we have covered the 10 to 15 MCQs from the PYTs, NEET PG, INICT and the multiple examinations. So please do focus on these three parts. You can cover the maximum 70% of the syllabus. So before we start, those who are new to this channel, please do subscribe and share with your friends. And now we are going to discuss about the pharmacokinetics. So what is the pharmacokinetics, guys? How our body is absorbed, distributed, and how our body is excreted that particular drug. So first start with the absorption. Absorption is most likely all the drugs will be by the passive diffusion, most of the drugs. And the another thing is that all are observed in the small intestine, like all in the sense 90% I was talking. So lipid soluble mostly and in unionized form. Okay, that is how we are going to see. For example, the acid drug is going to be into the acid medium only, the basic drug is going to be into the basic medium only. So this is how the drug absorption will be seen. But there are the two things that you have to remember for the drug absorption. For example, the extent of the absorption and the rate of the absorption. Extent of the absorption is mainly dependent on the bioavailability. Okay, how much the drug is absorbed. For example, if I say iv drugs are 100% bioavailability, whereas oral drugs they are only 70%, because the drug has to go through some process, conjugation, everything, right? Whereas the availability, why bioavailability of 100% in the iv drugs? Because we are directly giving the iv route into the venous system, directly it will reach the tissues. Next, rate of the absorption is mostly depends on the per unit time. So the amount of the drug absorbed in the per unit time, then we call that as a rate of the absorption. So here you can see the two differences. This is the extent and this is the rate. So the Tmax, the maximum amount of the drug which is reached the plasma concentration, that is the rate of the drug, and the extent of the drug will be the area under curve of oral and area under curve of the IV. This is how we are going to check the bioavailability of the drug. Next, distribution. Distribution, we all know that once we given the drug has to reach the tissues, and after reaching the tissues it will start working and to decrease the symptoms or to increase the side effects, right? That is how the drug is going to work in our body. So there are the two types, one is the high volume, another one is the low volume. What is the high volume? The most of the drug is embedded into the tissues only. Here you can see this is the vessel and very scarcely in the vessel, only the minimal amount, but the most of the amount will be within the tissues only. Whereas low volume, if you see in the tissues only, very less amount is absorbed, whereas still in the vascular there is a high number of the high amount of the drug is in the plasma only. So that is what the difference between the high volume and the low volume. In another words, extravascular and the intravascular. So why it is important? Because if you see the high volume drug, it is in the tissues only, right? This will be in the tissues. So whenever you are taking the plasma exchange from the vessels, you cannot do so, such that the dialysis is not effective in the high volume drug, such as chloroquine, beta blockers, digoxin, op poisoning, calcium channel blocker, opioids, and also amphetamines, impramine. This is a tricyclic depressants and the benzodiazepines. These drugs are very not good for, are not effective for the dialysis or the plasma exchange. Next, plasma binding proteins, such as some of the important drugs such as the acidic drugs, which will be only binding to the albumin, and some of the basic drugs which will be act for the alpha 1 acid GP glycoprotein only. So what are the examples for the albumin binding? Aspirin, antibiotics, anticoagulants, antipsychotics, and antidepressants. For the basic drugs, remember the most of the drugs will be ending with INE. INE. This is going to be the most of the basic drugs, such as the morphine, imipramine. All these drugs are the basic drugs only. Next, coming to the metabolism, the most commonly it is takes place in the liver. So the phase 1 mostly oxidation only. The enzyme that is involved is the cytochrome protein 3A4, that is the most commonly seen, and the phase 2 most commonly glucoordination. The enzyme is glucuronyl transferase. And what are the enzyme inducers, guys? Enzyme inducers, this will cause the drug failure. Why? Because the enzyme inducers will act more. So whatever the drug we took, that is going to be the decreased plasma concentration, so that the drug failure will be seen. The rifampicin, alcohol, phenytoin, phenobarbital, carbamazepine, cigarettes. These are the some of the enzyme inducers. Enzyme inhibitors. What are the enzyme inhibitors, guys? For example, this is the tissue where the receptor is going to act here, right? Enzyme inhibitor, what it is going to cause? It cause the drug toxicity. How it is going to cause the drug toxicity? Because what happens, this drug has to absorb only 100, right? That, but we gave the 500 because some of the will be excreted. But what happens, inhibitors will increase this concentration, so that in the place of the 100 it will be going to 200 to receptor, so that will cause the drug toxicity. And the isoniazid, valproate, quinidine, ketoconazole, disulfiram, and the erythromycin, these are the some of the enzyme inhibitors. Excretion, the most common site is the kidneys via tubular secretion, 80%. All are in the ionized form. For example, acid will be in the basic medium, basic will be in the acidic medium. Vice versa, it is going to be, and all are going to be the water soluble only. Next is zero order kinetics and the first order kinetics. What is the zero order kinetics? There is a constant amount of the drug will be excreted. For example, only the 10 mg should be per unit of the time it should be excreted. 100 mg, 90 mg, 80 mg, and 70 mg. Only the constant amount will be seen. So by that, the toxicity will increase and also half-life will be increased via excretion of this particular drug. And next, first order, the constant proportion. For example, 50 mg. Again, another 50%, another 50%, and 50%. So it will gradually decrease. So less toxicity and half-life is also constant for this. What are the examples? The zero order kinetics: alcohol, aspirin, heparin, warfarin, phenytoin, and the methanol. And the most of the drugs will be first order kinetics only. And next, moving on to the pharmacodynamics, how the drug is going to act on our body. So the most of the drug affinity is indirectly proportional to the dose. So if there is a high affinity, the dose must be low. If there is a low affinity, the dose is very high. So this will depend on the marker of the dose. Next, potency, another indirectly proportional to the dose. So if you give the more potent drug, that means the drug has the, if the drug has to be very in the less doses only. Okay, it should be more potent in the less doses. If there is a more dose, so it is likely to be less potent, and the efficacy is directly proportional to the effect of the drug. And next, coming to the, here you can see what is the efficacy, guys, the effect of the drug. So this is the time, this is the response of the plasma concentration. So the more efficacy, the drug will be very high. Okay, the more efficacy, the drug will be more high. The more potency, more low dose, I said, right? It will be more low dose, and there will be the potency in the left side. Okay, so from the examples, the A is more potent than the C, but the C is more efficacious than the A. That is how you have to differentiate. Next, competitive inhibition and the non-competitive inhibition. So competitive inhibition, we all know that some of the drug is going to act here at the active site, so which will increase the Michaelis constant, and next Vmax will be constant. So the drug will be right side of the shift. Okay, this is the drug that we gave, it will cause the right side of the shift. Non-competitive inhibition, the drug supposed to be cause here, but it is acting on the other side. So this is the non-competitive inhibition. So this will cause the decreased height of the curve. So Vmax will be decreased, and also the Km is going to stay constant. Next, therapeutic index. Therapeutic index is very important because it will tell us the toxicity and what is the efficacy and what is the toxicity. Whichever is lies between this, that is known as the therapeutic index. So this is the ED50, this is the TD50, efficacy and the therapeutic toxicity, and that will be determine the therapeutic index. Next, receptors. Which of the receptors, which of the drugs is going to act on the ion channel gated receptors? Glutamate, NMDA, serotonin, and GABA, and very fast acting and tyrosine kinase, insulin, IGF-1, and the HER2, and the JAK-STAT for the leptin, erythropoietin, growth hormone, and the prolactin. CGMP is going to show the natriuretic peptides, and nuclear for the thyroid, vitamin A, estrogen, and progesterone. Cytoplasm for the cortisol, vitamin D, androgen, and the steroids. And next, some of the the G protein coupled receptors such as the GS, which will be acting by the increased CAM pathway, salbutamol and the dobutamine, and the GQ via IP3 and DAG, that is for the oxytocin and the angiotensin. GI, which will decrease the CAM pathway like serotonin, alpha 2 and the histamine 3, and the G12 is for the Rho kinase, phosphatidylate and the nitrosphil. These are the some of the drugs and the receptors acting. Next, clinical trials, very important. The phase 0 is microdosing, phase 1 toxicity, safety, kinetics and the dynamics, maximum dose we are going to check. Phase 2 for the efficacy, and phase 3 is for the drug into the market. Phase 4 is for the post-marketing surveillance, and phase 5 is for the pharmacoepidemiology. So the first two phases like phase 0 and the phase 1, healthy individuals, and remaining all the phases will be on the patients only. Next, coming to the antibiotics and their mechanism of action. Cell wall synthesis, which will be inhibited by the penicillins, vancomycin, cephalosporin, piperacillin, amoxicillin, and the carbapenems. And DNA integrity inhibitors, metronidazole, mRNA synthesis inhibitor, rifampicin, rifampicin, DNA garage inhibitors, fluoroquinolones such as the levofloxacin, and protein synthesis inhibitors such as the 50S protein synthesis and the 30S. What are the examples? 50S will be like clindamycin, linezolid, macrolide such as the azithromycin. And 30S will be for the aminoglycosides like as amikacin, gentamicin, and tetra and the doxycyclines. Next, folic acid synthesis inhibitors, sulfonamides, and trimethoprim. Mycolic acid synthesis inhibitor, isoniazid, arbinogalactone synthesis inhibitors, ethambutol, intracellular inhibitor, that is the pyrazinamide, and lanosterol synthesis inhibitor is the terbinafine, ergosterol synthesis inhibitor is the fluconazole and the ketoconazole, nucleic acid synthesis inhibitor is the fluocystosine, and cell membrane integrity is disrupted by the amphotericin B. Cell wall synthesis of the fungus is inhibited by the fungi. Okay, these are the important mechanism of actions. Next, TB drugs, you have to know rifampicin is going to act by the DNA RNA polymerase inhibitor. And what are the side effects, guys? Orange body fluids, cytopenia, hepatotoxicity, pulmonary syndrome will be seen. And also it act via the CYP450 inducer. So OCPs and warfarin, the amount of the drug failure will be seen with this rifampicin. Isoniazid, it will inhibit the cell wall synthesis such as mycolic acid, cause the peripheral neuropathy, SLE symptoms, anemia and the hepatotoxicity. Why anemia? Sideroblastic anemia, which will inhibit the ALAS synthase pathway. And also vitamin B6 is should be given for the prevention of the B6 deficiency. Pyrazinamide, which will have the lower pH intracellular fatty acid synthesis inhibitor, it will cause the gout and most hepatotoxic. It is absolute contraindication for the pregnancy and the children, and it can cause the acidic environment active part of the pyrazinamide. Ethambutol orbinyl transferase, just now we discussed, decrease the cell wall synthesis, can cause the E for ethambutol, E for eye. It will cause the red-green blindness and the optic neuritis, contraindicated in the renal failure patients. Coming to the malaria treatment, we have the two types, Plasmodium vivax, Plasmodium falciparum. So Plasmodium vivax, which will be having the high risk of the relapse, so we are going to work that way. Plasmodium vivax in the pregnancy, we are going to give the primaquine, which is contraindicated. We choose the chloroquine for this patient. And all the states we are going to give, regardless of the northeast, eastern or the western, all the states we are going to start from the chloroquine 25 mg per kg and the primaquine for the next 14 days for the prevention of the relapse. Okay, what is the dosage for the day 1 10 mg, day 2 10 mg, day 3 5 mg, that is the chloroquine. Plasmodium falciparum, in the pregnancy we are going to give the quinine in the first trimester, whereas same as the other treatment in the second trimester. So primaquine is contraindicated as before we discussed in the Vivax also. So northeastern areas there will be having a more and more type of these patients will be having the more resistance to the drugs. So that's why for them we are going to form the ACT AL therapy. So ACT for artesunate, artemether, lumefantrine and primaquine for 1 day. Okay, so the drug that we are going to for the 3 days is the artesunate, artemether and lumefantrine that we are going to give for this patient. And remaining all the state act SP only. Artesunate, sulfadoxine and pyrimethamine and another primaquine for 1 day. So primaquine is basically given on the day 2 of the period of the treatment. Next, heparin versus the warfarin. Here you can see the heparin is a given in the IV and the subcutaneous form, and warfarin can be given in the oral form. And next, the rapid of the action via IV, because it will be having the rapid action. It will activates the antithrombin 3 and inhibits the 2A factor and the 10A factor, so that the clot formation will be prevented. And monitoring, you have to monitor the intrinsic pathway. APTT should be formed. And for the patients those who are in the pregnancy, it is safe because heparin and also the patient's insulin, it does not cross the blood placental barrier of the pregnancy. Antidote, protamine sulfate. Adverse effects, heparin induced thrombocytopenia and the long term use can cause the osteoporosis. And the warfarin, oral anticoagulant, it is very slow action. It will inhibit the vitamin K. So then if you understand, vitamin K is important for the factor 2, factor 7, factor 9, factor 10 and also protein C and S. So it will disturb the extrinsic pathway. So you have to monitor the PT and INR, and not safe in the pregnancy because it will cause the fetal warfarin syndrome. Vitamin K is the antidote, and skin tissue necrosis teratogenicity is the patient's warfarin toxicity. Next, some of the drugs and the specific side effects. Here you can see we are discussing about the lithium. It will cause the leukocytosis, diabetes insipidus, tremors and the teratogenicity like Epstein's anomaly, box-shaped heart, hypothyroidism, increased weight and unwanted GI symptoms. Amiodarone, it will cause again thyroid toxicity, abnormal LFTs, lung fibrosis, tremors and skin changes. Cyclosporin, it can cause the hypertension, hirsutism, hyperlipidemia, gout, gum hypertrophy, and also nephrotoxicity and the tremors. Phenytoin P40 induces hirsutism, enlarged gums, nystagmus, yellow skin, teratogenicity, and also osteopenia, inhibit the folate metabolism and neuropathy. Valproic acid, vomiting, alopecia, liver toxicity, pancreatitis, rash like Steven-Johnson syndrome, obesity, increased appetite, teratogenicity, and the enzyme inhibitor. Cisplatin, it will cause the cochlear toxicity, peripheral neuropathy, nephrotoxicity, high chance of the emesis, and decrease the electrolytes such as the magnesium and the potassium and the calcium. Digoxin, diarrhea and vomiting, arrhythmias, xanthopsia, colored visions, AV block, ventricular bigamy, confusion and the dizziness. And clozapine is very important antipsychotic of the second generation, constipation, agranulocytosis, hypotension, sedation, weight gain, seizures, increased salivation, QT prolongation will be seen. And carbamazepine, it will cause the ataxia, blood dyscrasias, and CYP450 inducer, diplopia, Steven-Johnson syndrome, teratogenicity, agranulocytosis. And methotrexate, myelosuppression, liver toxicity, oral ulcer, neural tube defects, it will decrease the folic acid synthesis, and renal toxicity, pulmonary fibrosis, and also alopecia and MSS and the infection. Gynecomastia is seen with the digoxin, cimetidine, alcohol, ketoconazole, and the spironolactone. Agranulocytosis is seen with the all C type of the drugs, carbamazepine, chloramphenicol, clozapine, carbimazole. Drug lupus, SHIP, sulfonamides, hydralazine, isoniazid, and the prokinamide. Pulmonary fibrosis, bleomycin, busfelvin, and also methotrexate, cyclophosphamide, amiodarone, and the nitrofurantine. Ototoxicity, vancomycin, amikacin, cisplatin, aspirin, neomycin, ethacranic acid, and the streptomycin. QT prolongation is seen with the antiarrhythmics of the class 1A, class 3 like prokinamide, quinidine, and also amiodarone, ibutolide, which will be seen. Macrolides, fluoroquinolones, and also antipsychotic, antidepressants, and the domperidone. These are the important points that you have to remember, and likely to be the part 1, part 2, part 3 you have read, and please read the notes and revise them regularly and compensate with the MCQs practice. So those who are new to this channel, please do subscribe and share with your friends, and stay tuned for the more nine another subjects also. And all the best and happy preparation, guys.